My name is Deanne Pelletier, and I'm Concord Hospital Trust Director of Annual Giving. I am pleased to welcome you to What's Up Doc, a monthly lecture program brought to you by Concord Hospital Trust. We would like to recognize and thank Walker Lecture Series for sponsoring What's Up Doc. The Walker Lecture Series offers a wide variety of programs on history, art, music, and science, as well as dramatic and literary performances. All events are free to the public and held at the Concord City Auditorium. What's Up Doc is proud to welcome Dr. McLeod today. Dr. McLeod's formal education includes the University of New England College of Osteopathic Medicine in Biddeford, Maine, and the New Hampshire Dartmouth Family Medicine Residency here at Concord Hospital, where he completed his residency in 2003. In his talk, Dr. McLeod will expand on the numerous physician and leadership roles he has held at Concord Hospital over the past 2 decades. Currently, he is Associate Chief Clinical Officer. Please join me in welcoming Dr. McLeod.
Hopefully it'll be everything that she said it was going to be, and be exciting. So when we were first talking about this, and for those who were here last month, you got to meet my wife, Angela McLeod, who is also a resident, a graduate of our residency program here. She did a talk on neonatal withdrawal syndrome in babies born here at Concord Hospital. We talked about what would folks want to hear about, and we thought that talking a little bit about really preventative screening recommendations through the decades. And as I thought about it, my wife said, well, maybe you should talk about how medicine has changed over your lifetime and your experience. And I thought, knowing the folks in the room, medicine's probably changed a lot more over your lifetime than mine, but I'll try to touch on it a little bit as we go along. But I came to Concord Hospital at the turn of the century in 1999, and then ultimately I've been here all but 1 year. My wife did a fellowship in East Carolina University in North Carolina. So I've been here really for the last 23 years. But I thought I'd talk a little bit about my evolution, not just as a physician, but all the different parts of my decade. So I came here as a single man and got married. And for those who saw my wife last time, I am now the proud father of 2 lovely teenage girls who were born here at Concord Hospital, I still say, raised more at the Learning Center here at the hospital probably than Angela and I, and are now 16 and 19. I have a sophomore in high school at Bow and a sophomore in college at Ithaca College, and the proud parent of 1 Labradoodle named Tuckerman. As they say, I've worn a lot of hats over my time here at Concord Hospital. So I came here as a medical student. I've been a resident. I have been faculty at our residency program here in Concord. I did a brief stint as the medical director for employee health. My longest running job here has been a family medicine physician, primary care physician at our office in Hopkinton. I've also been the lead physician for that group, our medical group's governance council. I did 2 terms as a member of the governance council. I've been the family medicine department chair. I worked for several years under Paul Clark as a clinical informaticist, so as much as I'm board certified in family medicine, primary care, I'm also board certified in clinical informatics. And for folks who say, I don't really know what that is, it's the concept from a medical specialty standpoint that this alone versus this plus this, you can do more with these 2 than this alone. So it's really the integration of technology into care. So amongst things, I helped to consolidate all of our separate then GE Centricity electronic health records into a single record for people at Concord Hospital, and then ultimately built our Cerner outpatient electronic health record and helped to implement that here. I am Concord's one and only Associate Chief Medical Officer. There's never been one before, nor will there likely be another one in the future under Dave Green. And now our current structure, which is my current role, I'm the Associate Chief Clinical Officer for Primary Care. So I'll talk a little bit about where our practices are, but I oversee all of the primary care activities at Concord. Up until this year, I've been a part of the hospital's senior management team. During COVID, I led the outpatient response. So all of your testing, all of your vaccines, all of the therapeutics done at Concord Hospital was all part of my scope of responsibility during the pandemic. And I even got an opportunity to be the medical lead for the state's SuperVax events at the New Hampshire Motor Speedway, which was really an amazing event. Vaccinated over 42,000 people for COVID, and was quite an event. I'm a big Will Ferrell fan, so I included pictures of Will Ferrell wearing multiple hats. That's the connection, in case folks didn't get it. Even Talladega Nights, where he is at a motor speedway. So my attempt at humor. So primary care, where are we? So we have 17 practices spread out around the central part of the state. We have most of our practices are family medicine practices. We do have 2 internal medicine only practices. We have 1 combination practice in Franklin, which is internal medicine, family medicine, and pediatrics. And we have 1 dedicated pediatric practice. We have 2 dental offices that I help to oversee, 1 here in Concord, 1 in Laconia. And the majority of our phone system for primary care is now answered in a central location. So most of the phones come into a central location and then get parsed out to the individual practices. They do all of our initial phone calls. They handle all of our refills, prior authorizations for medications, and new patients. We get calls for new patients somewhere between 25 and 40 new patients a day. So we continue to be active. All of our practices, except for 1, is currently has at least 1 provider accepting new patients. So we've really tried to grow and expand. I think the number as of this morning, we have 139 primary care providers with, I think the number is 79 physicians, and then the rest with nurse practitioners and PAs, and we continue to grow that group as well. So when we were talking about the preventative medicine over the years, obligatory, I have no specific disclosures. There's no drug companies that are paying me. I don't promote any particular product or testing modality. Today is not going to cover every screening recommendation, so there are a lot of things that I probably won't cover, but I'll try to cover the main things throughout each decade. Majority of the recommendations are going to be from the U.S. Preventative Services Task Force. That's what we utilize most. One of the things in our electronic health record that I don't know that a lot of folks realize, but we have 2 products. One is a registry. So when we talk about medical conditions like diabetes, we actually have a registry that we can see all of the folks with diabetes and how they're doing with preventative measures, be it eye exams, foot exams, certain medications. And then ultimately we have a product called Recommendations in the health record that allows primary care physicians, or quite honestly anybody else, to be able to see with the patient in front of you what services they might be due for, which helps to prompt and make sure that we help to keep folks up to date with all of the different preventative recommendations, of which there are many. One piece I thought I would note is one positive thing that came out of the Affordable Care Act is that insurers are required to cover anything that the U.S. Preventative Task Force recommends with a grade level A or B level of evidence. So the good piece is insurers are really required to cover preventative services for a lot of things that are preventative. Ironically, Medicare excludes themselves from that requirement, although they typically do cover most things that are in that bucket. Not all guidelines recommend the same thing. When I came here in the early 2000s, the recommendation, we'll use prostate cancer as an example, was all men aged 50 to 80 were recommended to have a digital rectal exam and a PSA every year. And the U.S. Preventative Task Force at that same time had recommendations that said no one should use this test to screen for prostate cancer. So if you think it was hard to counsel people when they said completely opposite things, it was. I would say the good news, and when we talk about screening, both groups now have very similar recommendation that makes it a lot easier. And breast cancer screening is another one that's gotten a lot of attention this year, where there are groups that recommend starting at 40, groups that recommend starting at 45, groups that recommend starting at 50, groups that recommend every year mammograms, groups that recommend mammograms every other year. So pretty much as long as you get some level of mammogram, you're probably following someone's recommendation, but it's part of our job to help to navigate you through that. And we'll talk about some examples of that. We really try to follow evidence-based medicine. What does that mean? That typically there are randomized controls trials that say that if you do this, this is what will ultimately come out of that screening, and showing that there's evidence, because there are things that we struggle to find evidence for. So we'll pick on poor Patrick Swayze, who got pancreatic cancer. Ultimately, if you said, well, did he have screening for that? The answer is no, because there is no evidence-based screening tool that's been found to be beneficial for pancreatic cancer. So in that example, there just isn't evidence for screening. Sometimes there's evidence that says that you actually shouldn't do something, that it actually leads to more harm than benefit, in which case, we'll talk a little bit about that. And then sometimes there is no evidence at all, and we rely on expert opinion. I really try to follow evidence-based guidelines as much as possible. And then I want to stress too that this is a focus really on screening. So there are sometimes testing, we'll use stress tests as an example. If you said, is there a recommendation for folks to have a routine stress test? I don't have any symptoms, I'm just a 52-year-old guy, soon to be 53 on Tuesday, no cards, gifts please. But ultimately if you said, well, there's probably a recommendation to have a routine stress test now that you're in your 50s, the answer is no, there's not. But at the end of the day, if I said, well, but actually I'm having chest pain, as a diagnostic workup for chest pain, stress tests would absolutely be indicated. Out of scope for what we're talking about today. It's really a focus on routine screenings and prevention in people who don't have a condition already. So I thought we'd start with the kids and work our way up. Maybe misplaced given the room, but at the end of the day, I'm sure you all have children, grandchildren, et cetera. So really with children, it's a focus on growth, development, and immunizations. That's really pediatrics in a nutshell. We follow here the American Academy of Pediatrics recommendations for routine vaccinations. The good news is in New Hampshire, the state of New Hampshire's children's vaccination program covers all vaccinations for children up through age 18 at no cost to the children or families, which is a great asset in terms of getting kids vaccinated. Developmental screenings are recommended at 9, 18, and 30 months, with dedicated screenings for autism at 18 and 30 months. We have embedded in our electronic health record the tool called MChat. It's a revised tool that ultimately can help to ask questions that might help to identify children who are at risk for autism. The recommendation for that screening is for all children. The state of New Hampshire recommends screening for lead at 12 and 24 months. Most every other state only recommends 12 months. Why does New Hampshire different? We have some of the oldest housing stock in the country, and the rates for lead in children are much higher than lots of other areas in the country. So with that, the state recommends screening at 12 and 24 months. For lead. I will say we've had a lot of challenges over the last few years. It was always hard when you'd see a 1-year-old in the office and say, and oh, by the way, then you have to take them to the lab to get someone to stick them with a needle to then get a check for their blood levels. So we had a lot of issues with compliance. We then had point of care tests where we could just prick a finger in the office and do lead testing. had some recall issues with that. So we're playing catch up with that. But I would say the good news is we're making progress on making sure all of our children here are getting screened for lead. Iron testing, hemoglobin recommended at 12 months. We see the babies a lot when they're first born. Typically, for most children born here, they get a baby's first homecoming with the VNA in the first few days when they get home. And then we'll usually see them somewhere between 2 and 4 weeks. And then a regular cadence at 2 months, 4 months, 6 months. We spread it out a little bit more, but we see them more frequently all the way up until age 3. In part because there's a lot of vaccine recommendations during that time. There's a lot of developmental milestones in terms of walking, talking, all the different things that you want to make sure kids are doing. And then safety pieces, that as they start to walk, making sure that folks are child-proofing their homes. And then really 3 to 21, it's an annual exam, really a focus on graduated pieces. So as they're moving out of their car seats into wearing seat belts, making sure they're starting to connect, usually at age 3 with regular dental care. And then healthy behaviors, regular activity, limiting screen time. We use, for folks who've heard of it, 5-2-1-0. 5 fruits and vegetables a day, 2 hours or less of screen time, 1 hour of physical activity a day, and 0 sugar sweetened beverages, soda, other things like that. And then as they get older, really talking to them about high-risk behaviors. We start screening children for smoking at age 11. You might say, really? 11? Studies have shown that kids start to experiment with smoking at age 11. I couldn't tell you more up-to-date information around, is vaping considered less problematic with children, but at the end of the day, we'll start that and then escalate that through their teen years. 20 to 40, this is an elusive group. They tend to disappear. They're on their parents' insurance. They go away to college. Maybe they get their own job. They get their own insurance. They sort of disappear. So we don't see them a lot, but if you said, what's evidence-based guidelines, really continuing to have a regular check-in every 1 to 2 years. Is recommended. Really at this point we're talking about checking things like height, weight, body mass index, talking about maintaining a healthy weight. Screening blood pressure in this group is evidence-based and recommended. We do depression screening. We do see some of the highest rates of depression in this group. Oftentimes folks feel like, oh, I'm coming to the doctors for my physical, I have to have blood work, and I have to have blood work every year. I will say when I first graduated from residency and tried to follow evidence-based guidelines, try to have someone come in for their physical and not do blood work. Because they'll look at you and say, well, if you're not doing blood work, why the hell am I here? That's what I wanted. It was like, okay, fine, we'll do blood work. But evidence-based really is every 5 years for your cholesterol for routine screening, and then ultimately if you have other risk factors, you can screen more frequently. Diabetes screening starting at age 35. Again, this is average risk folks, so we'll say given the weight issues that we do see, oftentimes screening sooner is indicated. Screening for high-risk behaviors, drug, alcohol, cigarettes, those sorts of things, and counseling folks appropriately. But it's really the big screening piece that kicks in 20 to 40 is cervical cancer screening. Again, when I first came here, typically women would enter into the cervical cancer screening world with a pap smear, usually about the time they became sexually active. Maybe we're looking for birth control, so that could have been in their teens or 20s. And at that point, it was a pap smear every year. And we really have evolved those guidelines now where U.S. Preventive Task Force recommends starting to screen with routine pap smears for cervical.
Medical surge, location ED, floor 1. Facility alert, medical surge, location ED, floor 1.
Really starting to screen at age 21. And 21 to 29 is every 3 years with a pap smear without testing for HPV. You see a lot of HPV, human papillomavirus, in younger folks that oftentimes will clear on its own, in which case they don't need, nor are they typically at risk for developing cervical cancer at that younger age. And ultimately, with the HPV vaccine, we're seeing less and less folks with HPV. And then when women hit 30 to 65, recommendation is every 3 years for pap smear, or If you do pap smear with HPV testing, then you can go to an every 5-year cycle. So rather than having pap smears every year, you can start to spread that out. So it's really that 21 to 65 range. They don't recommend screening with pap smears earlier, and you can age out of screening at age 65. So I typically, when I see folks after age 65, I don't get a lot of women who are really upset that there's a recommendation that wasn't their favorite thing to have done, and so they're usually okay. I always tell folks that recommendations are general guidelines, and for folks who say, I understand all that, I still want to screen, it's not that you can't, it's just if you said, is there evidence that continuing to screen for cervical cancer after age 65 is evidence-based? The answer is no. Yes, ma'am.
If you're high risk for some reason, like your mother took DES or something like that, would you continue after age 65?
So for high-risk individuals that have a different reason to screen, you may. There may be lots of reasons that you might. One of the sort of caveats down the bottom is typically women, for example, who have had a hysterectomy where their cervix has been removed, you don't need to continue to do pap smears. There's no evidence that's beneficial. However, if part of the reason you had a hysterectomy is because you had a high-grade cervical lesion for cervical cancer, then you might say that you actually would continue to do that, not so much for routine screening, but you're looking because you have a higher risk. So again, in certain higher risk groups, you may do things more frequently, but great question.
And it's okay to request that they do it?
Don't ever request anything from your doctor. Oh, we hate that. No, all of it really should be a dialogue, and I think part of it is, it's always fine to challenge, with the, are you sure? Because at some level, why do you say you're sure? Well, and part of the reason I want to continue to do it is because my mom had this exposure. I had this history personally. Oh, okay, actually I don't have that in your record, but based on that, let's have a conversation around it. So I think it's always good to ask, request, ask for clarification, because we really want it to be a partnership. We really want it to be, a give and a take. I think the day and age of like, I own all the information and you just come and you do whatever I say, even back in the day, nobody ever did what we said all the time anyways, but you do want it to be more of a dialogue, more of a conversation, and we want patients invested in their healthcare. One of the reasons that we have an electronic portal where folks can see their labs, see their office visits, things in our electronic health record is we want them to be an active participant in their care. So I would say it's absolutely fine to request and ask about that. Great. So 40 to 50, it's still everything that your 20 to 40, but really this is where we start to have conversations around colon cancer screening. 45 is the new 50 for colon cancer screening, where it used to be you'd start colon cancer screening at 50. Why did they move it back? Really what we saw is there was a small subset of folks who were being screened at 50 and being diagnosed with not precancerous polyps, but actual colon cancer. And as much as we call it colon cancer screening, we're actually not hoping to find colon cancer at all. We are hoping to find precancerous polyps that you can remove that will never turn into a cancer. So because they were seeing a group being truly diagnosed with colon cancer at 50, they moved it back to 45. They did that in the middle of the pandemic, so our poor GI group is trying to catch up from not doing colonoscopies for a while, and now 5 more years of our population qualifies for colon cancer screening. But for folks 45 to 75, the recommendation is if you're doing a colonoscopy for routine screening every 10 years, if you do have polyps that are removed that are precancerous, you become the reason for which we screen, in which case most of the time they'll recommend a repeat in 5 years. If you said, well, I really don't want to have a colonoscopy, there are some alternatives for routine screening. There's 3 approved pieces. Fecal occult blood, which is it's approved, I will say we don't really use it anymore. A lot of false positives with that. So if you had a big juicy steak the night before, had some hemorrhoids, there's potential where that test could be a false positive. We use in the office what's called the FIT card, next generation of that, which really looks for microscopic breakdown products associated with blood in the stool, cuts down on the number of false positives. Cards are considered accurate screening as long as you do them every year. So for folks who are seeing us yearly, it's a great alternative to a colonoscopy if they don't want to have the procedure. And then the newer test, which folks have probably seen in magazines and ads on TV, Cologuard DNA test. Personally, I tell my patients, it's not that I don't recommend it, but the workflow to get it done is a little clunky, and it instead of getting you 1 year, it gets you 3 years, but stool cards are around $25, Cologuard is around $800, so it's a more expensive version. For folks that want to do it, I'm happy to support it, but at the same time, try to be cost effective in what we do and what we recommend. But colon cancer screening, really from 76 to 85, it's more of a discussion of what do you want to do? One of the conversations I have with folks really around routine screening is when there's evidence basis, we'll talk about what does that look like. But if we were to say, for the sake of the argument, if we were to take a 76-year-old and say, look, I'm not really sure if this is evidence-based or not, so what I'd like to do is take you and 1,000 people just like you and follow you over the next 10 years. I'm guessing you can guess the flaw in that study. The majority of the people in our study probably won't be there at the end of 10 years to be able to show that there's benefit or not. So when we say, is there evidence that continued screening? The answer is no, not really. So part of it really is a discussion based on what are your risk factors, what's your overall life expectancy, what are your other comorbid conditions to say, if you're 76, you're otherwise healthy, everybody in your family has lived to 105 and you want to continue to screen for colon cancer, the answer is, sounds great, you can continue to do that. But at the same time, for a lot of folks, by the time they're in their 70s or 80s, really there may be other medical conditions that may not make that beneficial. I use the example with patients, if they gave me a crystal ball to say, look, you're 76, and if we did a colonoscopy today versus not, I can tell you right now that you die at 82 of a heart attack in your sleep. Good, that's how I want to go.
Why not just use the card for $25?
Oh, you could use the card as well, colonoscopy or screening. It would be more the question of do you want to do it at all? But if you said, well, by screening at 76, instead of dying from a heart attack at 82 in your sleep, we identify that you have a colon cancer that probably or may not cause you a problem until your late 80s. But because we have identified it, then we've talked about surgery, we've talked about chemotherapies or other therapies, in which case, instead of dying at 82 in your sleep, you die at 80 of complications from your chemo and other things. Well, it didn't make you any better from screening and actually might have made you worse. Now, they don't give me a crystal ball. I can't predict the future. So part of the discussion with individuals around what do you want to do is, would you want to know that information? Would you want to continue to screen or not? And so I think part of it is, and back to your question before, for folks who want to continue to screen, it's not that they can't, but at the same time, for folks to say, I've had enough of that, I think I'm done, typically they can age out of that screening at 75.
At one point there was like the full body scans or something.
Oh, yeah.
Did that ever gain legs? Right. Is that,
Yeah.
remember that?
So there was a period of time, I think in the 80s, 90s maybe, where you could go into a mall and get a full body CAT scan, head to toe. And I would tell you right now, if anybody were to ever offer it, even if it's free, run the other way. Because in part, that I will guarantee there are things in all of our bodies right now that we don't know about, may or may not ever cause us a problem, but we're not aware. But you could take someone who's otherwise healthy and say, just so you know, there's a few spots on your brain, and I think it's a cyst on your liver, but I'm not really sure, maybe a biopsy, and there's some things on your kidneys and what have you. I mean, we all have that, but when you identify it, you go from being healthy to, I have a brain problem, a liver problem, a kidney problem, and you feel less healthy. So there was never any evidence for that. The good news is I don't think anybody's doing that anymore. But there's always, again, risk for screening. Breast cancer screening is the other topic, really, when we get into that 40 or 50 year range. U.S. Preventative Task Force currently recommends starting at age 50. They have a draft recommendation that I think will likely be put in place in 2024. That will move it back to 40. But there are groups that recommend starting at 40 and annual. American College of Radiology, for example, recommends that. There are groups that recommend starting at 45. U.S. Preventative Task Force currently at 50, but will likely move that back to 40. They recommend biannual mammograms every 2 years rather than annual. But I think part of it is really around breast cancer screening. I think the bottom line is, while there are multiple guidelines, somewhere in the 40 to 50 range, year-old range, starting to do breast cancer screening. And one of the things at this point now that most groups have moved away from is the concept of recommending that women do self-breast exams. Ironically, the American Cancer Society promoted for a while, I think they backed off with this. We don't recommend self-breast exams, but we do promote breast awareness. I'm not really sure what that means. Like, be aware that you have them. I think the concept was you shouldn't check them regularly for bumps because patients, and quite honestly, even clinicians, aren't very good at identifying this is a problem, this is not. Mammogram is much better for that. But at the same time, if you said, well, I've got this big lump that just keeps getting bigger and it bleeds and everything else, don't ignore it, which you'd hope nobody would do anyways. But at the end of the day, self-breast exams really have not seemed to improve longevity or change treatment options, in which case most groups don't recommend that. And sometimes folks will ask, and I've heard Dartmouth-Hitchcock is doing this, well, it pinches, I don't like it, is there another option? And the answer is no, not really. There's not good evidence, the U.S. Preventive Task Force says there's insufficient evidence for breast ultrasound, tomosynthesis, or breast MRI for routine screening. There are reasons to do ultrasounds more diagnostically to figure out what's going on, but in terms of for routine screening, the answer is no. So 50 to 60. It's still everything 20 to 50. They recommend at 50, really coming in yearly after that. 50 is really where we kick in conversations around prostate cancer screening. And as I alluded to earlier, guidelines had previously been fairly disparate. Both groups now have a version that recommends that for men age 55 to 69, to have a conversation around the risks and benefits associated with prostate cancer screening. And when we're talking about prostate cancer screening, we're talking about with a blood test, PSA test. And ultimately, what we know from years of screening is this test is able to detect prostate cancer. But we know the majority of men identified as having prostate cancer with this test would live their lives, die from something else, never known they had it had they not screened. And the intervention does lead to potential risks where incontinence of urine, erectile issues, potential damage to surrounding tissues, so that both groups now say that rather than as a routine test, you should have a conversation with your practitioner around risks and benefits and have that be an individual decision to screen. And so I typically will order some routine blood work for folks, and then when they come in, talk about prostate cancer screening and say, if you want to do this test, I'm happy to do it, but I would want you to know that there are a lot of limitations to the test. Ultimately, we've continued to, during my 20 plus years doing this, looked for better tests for prostate cancer screening, and unfortunately nothing has really panned out for that. So at this point, they recommend 55 to 69, and American Urological Association says if you're going to do it every 2 to 4 years, I usually tell folks every 2 years, it cuts down on the number of false positives. And then lung cancer screening is a relatively newer recommendation, newer being probably in the last decade. We've looked for screening tests for lung cancer for years. Folks have tried chest x-rays, other things, but nothing has really panned out. There is now recommendation from the U.S. Preventive Task Force to do lung cancer screening in men and women age 50 to 80 with a 20-pack year history. For those who don't know what a pack year is, if you smoke a pack a day for 20 years, that's a 20-pack year history. If you smoke half a pack for 40 years, that's a 20-pack year history. If you smoke 2 packs a day for 10 years, that's bad, don't do that. But at the end of the day, that would be a 20-pack year history too. And have either are still smoking or have quit smoking within the last 15 years. With an annual low-dose CAT scan, we do that here at Concord Hospital as a potential screening. I'll dig into, again, when we talk about like, should you do something or not, or when we talk about evidence, what does that mean? But at the end of the day, I'll leave it as there's a recommendation to do that. And then when we get into 60 to 75, still annual exam, everything that we said from 20 to 60. And then Medicare, welcome. Medicare, throws a little bit of a wrinkle into things. So what I typically share with folks from a prevention standpoint, when I started doing this job, ultimately Medicare did not cover any form of a wellness visit or physical. So if you said, I'm 65, I just went on Medicare, I want to come in for my annual physical, my answer would be, happy to see you, happy to do that. Medicare does not cover that at all. Medicare was really problem-based in terms of what they covered. About, I think 12 or 13 years ago, Medicare instituted what was referred to as, or still is, the annual wellness visit. And really it's Medicare's version of an annual checkup to make sure that people are up to date with preventative screenings. And what I tell folks is Medicare exists on a spectrum. Some of that's here in the room today, but the folks who turn 65 versus the people who are 105, we do the same screening for everybody. So typically if we ask you, have you fallen at 65, it's usually because you slipped on the ice or tripped over the dog. When you're 105, it's oftentimes because you're a little unsteady on your feet and maybe a cane or walker would be beneficial. One of the things that folks will sometimes get a little hung up on is it does not cover a physical exam. As much as we talk about a physical or use the term, the least evidence-based thing I do in younger adults is an actual physical exam. It's never been evidence-based to listen to someone's heart and find something that's meaningful that they don't have a complaint for. We do it because that's what's involved with the physical, but Medicare had sort of said that's just not something that we're going to include. It doesn't mean that someone can't listen to your heart or lungs, but it's usually problem-based rather than just routine screening. The two unique things that kick in really in this age bracket, abdominal aortic aneurysm screening, so looking for an enlargement in the main blood vessel in your abdomen. Medicare will cover that as a screening, and there's evidence for that for folks who are 60 to 65 who have either a family history of this, and I reminded my dad as I was driving here because he's going to his doctor after his repair for his AAA aneurysm. Thanks a lot, I've got a family history now. When I turn 65, at least I'll know it'll be covered. Or evidence basis is for men aged 65 to 75 who've ever been a smoker in their lifetime. Definition, because you've got to define everything, that's defined as at least 100 cigarettes, so 5 packs over your lifetime that you would have smoked, you would qualify for that. If you said for asymptomatic women, no. For women who have been smokers, no, there's no evidence. Medicare doesn't cover it for that group, but they do cover it for family history. It's not evidence-based, and that's why they don't cover it.
What does that mean? What does that do, the abdominal aortic aneurysm? What does that do to you?
So it's the main blood vessel supplying blood all to your legs. So if you have an aneurysm is a dilation of the blood vessel, what does it do to you? If that dilation were to break open, you imagine you dump a lot of blood into your internal cavities really quickly, in which case, bye. So identifying earlier and repairing it is a good thing. And then the other screening is bone density testing. So a lot of debate over bone density testing over the years, not so much for the test itself. The test is just a fancy x-ray. It's indicated for women at age 65 or earlier if they had some risk factors. So if women were a smoker, if women had diabetes, women had thyroid issues, you could absolutely screen earlier. But for normal risk women at age 65. For men age 75, especially if they've had risk factors, a lot of the treatments for prostate cancer, for example, will up men's risk for potential for bone density issues. Issue with bone density testing has been less about the actual test, it's more about the drugs to treat it. When I first started here, the bisphosphonate class of medications, Fosamax as an example, Boniva, Mary Tyler Moore used to hawk Boniva on the television, ultimately have sort of a bad reputation where typically the dentist won't touch you. I think it's gotten better now, but they were always concerned about issues with the jaw. So if folks were on that, they would say, you know, we won't do any dental work on you unless you're off it for 6 months. The orthopedists, a little bit less, but they're concerned again about doing hip replacements or things when folks are on this for concerns that it might impact bone healing or things. But I would say at the end of the day, there are some effective treatments for that, and if women want that screening at age 65, it is evidence-based to screen. We're on the home stretch, folks. We've gotten to 75 plus now. So at this point, I typically tell folks, and this is updated information, average life expectancy in the United States for women is 79, for men, 73 and a half. So when we're talking about 75, most men don't live that long. Women do, good job. But at the end of the day, when you then start, and we talked about this a little bit, to say continued screening, what's evidence-based? There's not a lot of evidence basis for continued screening for all the limitations that we talked about earlier. So most of that really is going to be shared decision-making around what do you want to do. If you wanted to continue to screen or do things, you can absolutely do that, but at the same time, you can age out of particular screening recommendations. One of the things, because when we talked about evidence going back to lung cancer screening that I share with folks, just because there's evidence to screen for something doesn't necessarily mean that you want to do it. I provided one sort of infographic that's out there for lung cancer screening. But what I counsel folks is, if you were to screen 1,000 people who are at risk for lung cancer based on the treatment guidelines, the good news is a little over 600 of them are going to have a normal test. So that's what you want, someone pat you on the back to say everything was normal. The bad news is about 350 are going to have an abnormal test that ultimately someone's going to say, well, it's not normal. It'll end up turning out not to be cancer, but what we're going to do is we're going to repeat in a year. For any of the women in the room who've had an abnormal mammogram, the good news is you typically, if you need to have repeat pictures, you usually have it done the same day or within the same week, so you at least don't have to worry about it forever. For this, though, this group has to sort of worry about, well, it wasn't normal, but they said it wasn't lung cancer, but they get to think about that for a year. Out of that, about 40 people will be diagnosed with lung cancer. 7 of those may not actually be lung cancer or may not impact them. So really, when you boil it down, the group out of 1,000 people being screened that gets benefit is 3. And those 3 will have a lung cancer that is detected at a stage where they can have a surgery to remove that part of their lung, and they are now cured. So the good news in that screening cohort is you can have an impact. I always tell my specialty folks who are like, everybody should be having this test, this is really important, because I can impact those 3 people. I tell them I have to work with the other 997 and all the consequences of the 350 who have abnormal tests and are worried about that, the folks who ultimately are diagnosed with their lung cancer a little bit early, but there's no way to cure it, so they just know about it. It's not a reason not to screen, and it's multiple groups feel that this is enough evidence to continue to screen. But when you get in the details around, so what does that mean? It's not a slam dunk. And I always remind folks that they're still most at risk for heart disease. So at the end of the day, it's still really important for them to stop smoking. But this is just one example of some of the things where there's evidence, but not necessarily the right decision for all folks. I figured I'd leave vaccines to their own separate piece, but typically the recommendation is everybody 6 months and older should get a flu shot. Not a lot of debate about that. For folks 65 and sometimes earlier with certain risk factors, a one-time dose of a pneumonia vaccine. Current state is what's called Prevnar 20. That's what we use. Folks in the room, if you've gotten it in the past, it may have been what was called Pneumovax or Prevnar 13 or a combination of those two. Current state, though, recommendation is for Prevnar 20 one time. Shingles is recommended for folks 50 and older. It's a 2-dose series. Vaccine is very effective at preventing shingles. Shingles is caused by the chickenpox virus, causes a very exquisitely painful rash somewhere wherever it breaks out. Vaccine is 98% effective at preventing it, which is great. And a 2-dose series starting for folks at 50. RSV, the newest vaccine to come out and be approved, recommended for folks 60 and older. Ultimately with RSV vaccine, I got a lot of questions about that. It was approved really with recommendations that for folks having some level of shared decision. We'll contrast it with COVID vaccine. COVID vaccine, we know from studies with that it can help to prevent severe illness, hospitalization, and death. Typically things that are important to folks. We know, and it's not been for quite some time purported to prevent any illness. RSV vaccine was approved showing that it can help to prevent illness. Not necessarily, it could just prevent all the mild illness, but not the severe illness. We'll know more about that data probably throughout the course of this year, but the initial study was approved to just show that it can prevent illness. And there's 2 products that are out there, but both of them have very similar data from their studies. Out of the 18,000 people studied, 3 in both groups had some neurologic complications that it wasn't clear that it's related to the vaccine or not, but with that, they had said for high-risk individuals 60 and older, we would recommend it. For average risk folks 60, having a discussion about risks and benefits, I typically tell my patients, I think you can get it safely. I don't think anything bad is going to happen, but at the same time, if you're not that person who typically wants to run out and get the thing that was just approved, I think waiting for this one is okay in low-risk individuals. COVID vaccine, current recommendation is folks 5 and older. We'll see what the evolution of that is. I think with more and more folks having herd immunity from previous vaccinations, illness or a combination of both, it may be hard to continue to show that it's preventing severe illness, hospitalization, and death because we're seeing less of that. But current state in 2024, the recommendation is folks 5 and older. Tetanus booster every 10 years. With a one-time for folks who haven't had one since they were a child, tetanus pertussis booster. Pertussis is what causes whooping cough, and about 10 or 15 years ago, we had an outbreaks around the state for whooping cough, so updating folks with that. And one of the things which I thought was an interesting move, in 2023, Medicare made a move to cover vaccines, broaden their coverage, which was great, but they did it in sort of an interesting way. So, as I did this morning when I was seeing patients, if you want a flu shot, a COVID vaccine, a pneumonia vaccine, or with certain risk factors, a hepatitis A vaccine, I can do all of those vaccines in the office when you have Medicare or Medicare replacement plan or et cetera. But if you want to get shingles, tetanus, RSV, or hepatitis B with certain risk factors, you can only get those through a Part D plan with your Medicare, if you have that, at the pharmacy. Now, ironically, you can get all of my vaccines at the pharmacy, but you can't get the pharmacy vaccines in the doctor's office. I'm guessing it has something to do with payment or something else. But the good news is there's broader coverage for vaccine coverage for Medicare beneficiaries than there had been in the past, which I think is a plus.
A question on the shingles.
Yes, ma'am.
What if you've had one of the 2-part but didn't go back for the second one, now it's been 2 years? So you got one vaccine.
You have a hard time following instructions. But you should get the second one. Even if it's been an extended period of time, the series is most beneficial with both vaccines. And you don't have to do the 6 months. Even if it's been more than 6 months, still getting the second dose would be recommended.
But I don't have to start from scratch?
You don't have to start from scratch.
Beautiful.
Yes, ma'am.
On the pneumonia vaccine, if you've had the Pneumovax and Prevnar 13, should you still get the 20?
Nope, you're done. It's just for folks that when folks walk through the door today, if they haven't had any of those, it would be Prevnar 20. So this is honestly my last slide, aside from, do you have any questions, I promise. So what didn't you hear from me? We'll touch on some of these already. So there's lots of things that folks will ask for that really don't have evidence base. So folks will often want to have their thyroid checked routinely. If you're gaining weight, losing weight, your hair's falling out, you're depressed, there's lots of reasons to check thyroid, but just routine screening, nobody recommends that. Everybody wants a vitamin D level, no recommendations for routine screening for vitamin D. Again, if you've had bone density issues, a lot of different things, reasons to check it, but not as a screening test, and really nobody pays for it for a screening test. Older test, but it was used a lot, homocysteine. We talked a little bit about stress tests. People are always asking me about vitamins. No great evidence for anything for vitamins. Not really a screening test, but I thought I'd throw it in there anyways. Ovarian cancer, prostate cancer, no good screening tests for that. And then my favorite one is folks will always ask me, well, what's my blood type? I have no idea. Well, as my doctor, don't you think that would be important to know? My wife finds it very ironic, or maybe not, that my blood type is B positive. But ultimately, I tell folks, even if it was tattooed across my chest that my blood type was B positive, they would still test my blood. There's lots of other sub things that they look for. And if there was ever an emergency where they didn't know my blood type, I would get O negative blood. So at the end of the day, there's really no benefit. I tell folks, which is a great thing to do, donate blood, and they will tell you your blood type. It's a great way to find that out and be helpful. So thank you very much for listening to me. I'm happy to answer any questions you might have.
What is homocysteine? What's
So homocysteine was a test that I think was popular in the early 2000s. Homocysteine is an amino acid. You can measure it in the bloodstream. And what they found was people who had high levels of homocysteine had a higher risk of developing heart disease. And so with that, they then found if you give folks folic acid, you can actually get their homocysteine levels to go down. And so everybody was checking homocysteine levels. Everybody was putting people on folic acid to try to lower their homocysteine levels. And what they found from studying that afterwards is treating folks with folic acid didn't change your heart disease risk at all. Homocysteine wasn't the thing that caused heart disease. It was just a marker. And we have much better predictive markers for heart disease than that particular test. And there's actually studies that show for non-pregnant women, routine supplementing with folic acid actually increases your overall cancer risk slightly. So at the end of the day, there's no good reason to do it, and there's potentially a low-grade risk not to do it. So I would say that one has fallen out of favor a lot, but it was something that folks would ask for. That's it. That's what I got.
I have another question. It's kind of personal. What are the risk factors, or are there any statistics on risk factors of people that are over 85 that have had polyps developing colon cancer?
So I would say for folks who have had polyps in the past, part of it would be, I don't know that I could give you a specific. We know that there's potential that and part of the reason we do a colonoscopy in 10 years is if we said, part of the reason we picked the interval of 10 years is if you had a polyp that started growing the next day after your colonoscopy, so it wasn't there the day you had it, it started growing the next day, it will take 10 years to get to a size to ultimately need to have some intervention for being removed. So the good news is you've got a 10-year window. So for someone who maybe had a colonoscopy at 75 and then had whatever dealt with, the likelihood is any particular polyps or things are probably not going to even cause you a problem in terms of size until you're 85. And before they would cause a colon cancer that might need to be intervened with, you might be even further out. And at that point, there may be other things that might impact your health. So it's hard to predict. I think, again, for folks who say, my last colonoscopy when I was 75, they removed like 12 polyps. You might be someone who still wants to have a colonoscopy at 80 if your health is good. But at the same time, if they removed 1 or 2 polyps and you said, I gotta be honest, I just don't want to have that done anymore, you don't have to. Deanne.
I had a quick question in regards to children. When you check for lead and the lead levels are high, does that just prompt a conversation with the parent about where they're living, what to do? I mean, like, is there anything you can do?
Yep, so it's a great question. So there's a couple of different pieces. The first one is when we do a screen, if it comes up positive, we'll typically then do a formal lead level in the lab with what's referred to as a venous draw, so to make sure that it's not a false positive. One of the things that we have to do with kids, which is very fun, especially at that age, we've got to wash the hands really good, dry everything, because touching surfaces, they could have surface lead that isn't in their bloodstream, that you don't want to contaminate that. But once we've confirmed that their levels are high, all of our lead results go to the state of New Hampshire. So in addition to having conversations with them around preventative measures, the state actually gets involved. And part of that is everything from an inspection to the home, doing lead testing in the home. For folks who rent, ultimately having conversations with landlords about abatement, if it's environmental around mechanic or other things, potential to abate lead issues. Same thing if you own your home, talking about ways to try to cut down on lead exposures. And then for us, it's really more of a sequence of retesting to make sure it's coming down. Great question. Anything else I can answer? This is what I do day in, day out, every single day. I do probably 8 to 10 annual wellness visits and physicals every time I'm in the office. So I spend a lot of time talking about this. I'm very passionate about it, very much enjoy doing it. It was wonderful having you all, and I hope you enjoyed your lunch.
Well, you do a great job.
Thank you.
So thank you very much for coming today and sharing this with us. And thanks to everyone for joining us. Our next What's Up Doc is February 9th, where we're going to coordinate Heart Health Month of February and get a physician to speak about heart health. I'm not exactly sure what the topic's going to be, so stay tuned. On behalf of the entire staff, thanks again for presenting today, and I hope you have a great day and weekend.